Ladies and gentlemen, welcome to this final session for today. My name is Nick Macklin. I'll be co-chairing this with my colleague, Professor Christos Venetis from Greece, and it's going to be a very topical session. You know, those of you who've read Bob Edwards' book, The Matter of Life, which I would recommend if you haven't, it's a very short read, but it's remarkable how he already saw back in the 1970s how important frozen embryo transfer was going to be. And we've all lived through, many of us, through the changes that vitrification brought. And frozen embryo transfer remains a very hot topic in our clinical practice, as you all know. So we're going to enjoy 4 speakers presenting on this topic today, very clinical talks, which I think you'll find very interesting and relevant to your practice. So I'd like to start by inviting the first speaker, Mikhail Shuaib from King's College in London, a Year 3 medical student. Congratulations. Come on up, and we'll look forward to your presentation entitled Comparative Effectiveness of Endometrial Preparation Strategies for Frozen Embryo Transfer, a Network Meta-Analysis of Live Birth.
Thank you to ESHRE, and thank you to the co-chairs for allowing me to present. My name is Mikhail, and I'll be discussing today the comparative effectiveness of endometrial preparation strategies. We performed a systematic review and a network meta-analysis. I have no conflicts of interest to declare. So as just mentioned, frozen embryo transfer accounts for the majority of embryo transfer cycles worldwide nowadays, and the optimal endometrial preparation intervention is one of the most consequential decisions as a result of that. We have a natural cycle as an option, a modified natural cycle, a programmed HRT cycle with an agonist, a stimulated cycle, and then a programmed cycle without an agonist. So why is this study actually important? The previous reviews and literature relied mainly on pairwise comparisons on the selected interventions, and we were able to generate direct evidence. However, what remained was the indirect evidence across the 5 interventions that could not be synthesized simultaneously. The complete comparison across all the interventions has not actually been done, and therefore it's not possible to construct a comprehensive clinical hierarchy. The indirect evidence, as discussed, remains unused, and this network meta-analysis is the first to integrate all 5 interventions in a connected evidence network, and we're able to create 10 complete pairwise interventions from direct and indirect evidence available. So what do we actually want to know? We want to know, in women undergoing FET, which endometrial preparation strategy is the most optimal in terms of efficacy. So we performed a study. We searched our 3 databases until October 2025, and we obtained RCTs of high integrity, fully published in English, comparing different interventions. Our primary outcome was live birth rate per woman randomized, and we also looked at clinical pregnancy rate and miscarriage. We assessed the integrity of the RCTs using the TRACT checklist, which assesses different domains, and we assessed our trials for risk of bias using the Cochrane risk of bias 2 tool. Our statistical analysis performed using state data, and we were also able to calculate super rankings from the network estimates. So we had almost 4,500 records from the databases. We removed automatically 1,160 using duplicates. We further went to screen over 3,000. We sought 77 for retrieve. We could not obtain 22 due to different reasons. We assessed 55 and 48 criteria, and then went on to include 7 in the review and 7 in the network analysis. These were our included studies. This is a visualization of our risk of bias assessment. And so we were able to obtain direct evidence from head-to-head comparison of the interventions available on RCTs. We then went on to form our network and be able to implement an analysis. A combination of direct and indirect evidence estimate the relative effectiveness of interventions. We then obtained indirect evidence as a result of the network, and we were able to calculate super rankings. So our 7 high integrity RCTs comprised almost 3,198 women across five interventions. So on the results, this is our network for live birth. As you can see, it's a visualization of our pairwise comparisons. So we have our HRT at the top, our natural cycle, modified natural cycle, and the straight lines are representations of RTs that have the comparison available. As you can see, there's a thicker line between HRT and natural cycle that represents the 4 RCTs, so more available. The curved dashed lines represent indirect inferences, which can be formed from the other pathways in the network. And we had 7 trials contributing to direct evidence across 7 of the 10 pairwise comparisons for live birth. We were also able to obtain 3 comparisons from indirect inference that wasn't available directly, but we had the indirect available. As you can see, the dashed line across natural cycle to stimulated cycle is one of these. This was our network for live birth, and what is shown is that the network estimates show no statistically significant differences between our interventions. Confidence intervals also overlap. We'll come on to the super ranking for the HRT versus natural cycle, but ranking should be interpreted cautiously as the network estimates don't support a statistical difference. Here we have a similar network for clinical pregnancy. Our 7 trials contributed direct evidence across 7 of the 10 possible pairwise comparisons, and we had 3 comparisons with no direct RCTs, relying on indirect inference. As you can see here, again, the network is well connected like live birth, as live birth and clinical pregnancy are related outcomes. However, our core outcome was live birth. Here is the network estimates. Again, there's no significant differences across the interventions. As you can see, what follows quite similarly, if you have a look at the direct RCT pairwise estimate for the HRT versus natural cycle, it follows quite similarly to the network estimates. And if you follow along the interventions, you can see a similar shape formed with the network estimates to the direct comparisons. And what that does is it further validates our network indirect only estimates for validation, as it supports this. We only had 4 trials that reported miscarriage, and the network is substantially sparser and less connected, as you can see here. We had, again, indirect inference for some of the connections, but due to a lack of data, it wasn't able to form, but we formed a network. All of the confidence intervals crossed the line of no effect, so there was no comparison that was statistically significant. The confidence intervals are substantially wider than live birth or clinical pregnancy, and this reflects our sparse event data. There was also high heterogeneity in the HRT versus natural cycle direct comparison. Now, some of you may not have seen this before. However, SUCRA is a statistical measurement we use. It complements the network meta-analysis, and it gives us a probability of an intervention ranking as the most optimal compared to the others. It compares them all simultaneously. As you can see for live birth and clinical pregnancy, we have a high SUCRA ranking. The surface under the curve is what SUCRA stands for. And what this reflects is most likely a probabilistic outcome of HRT ranking as more optimal for live birth and clinical pregnancy. For miscarriage, you'll notice that, is it saying natural cycle is more likely to have miscarriage? It's actually not. We accounted for this in our statistical analysis, and natural cycle carries a lower chance, or natural cycle, the SUCRA ranking reflects, has a higher probability, for ranking as the optimal intervention. However, the data does not support this due to the sparse data available across the trials. So the study had quite a few strengths. We selected live birth as our primary outcome, as that is the goal with FET. We only included the high integrity RCTs, and we also used a random effects model throughout, which accounted for clinical and methodological heterogeneity across the trials. we also assessed our indirect evidence bias with the cinema tool. Only 7 RCTs were available. Coming on to our limitations, our miscarriage network was sparse due to the sparse data available across the trials. And we also did not include obstetric and perinatal outcomes, which would be our safety outcomes, which require future work. So to summarize, this was the first NMA to ever compare all 5 endometrial preparation interventions simultaneously. And in the largest NMA, we found there was no significant statistical difference across the 3 outcomes, with all FET strategies available being comparable in efficacy. So to take home, no endometrial preparation strategy demonstrated superiority for our 3 outcomes, and the protocol choice should be individualized, not standardized. So we treat the patient based on the patient's individual needs, monitoring burden, own preference as well, what's clinically suitable. I'd like to acknowledge my peers, and thank you so much for letting me present, and thank you so much.
Thank you. So we have time for some questions. Just if you would like to ask a question, please go to the microphone. Give us your name and where you're from, please. Frank.
My name is Frank Broekmans from the Netherlands. Congratulations with beautiful work. Now that your conclusion is that most of the systems that you presented are equally effective, it's up to you to choose your preferred method if you would have frozen embryos.
If I was having frozen embryos?
Yeah.
Wow, it's a very good question. I'm not sure. I don't know, maybe I'd like to treat my partner myself. I could give her a HRT cycle, why not?
Well, I would also wonder whether you would have sufficient information to choose, because one of the other things in this discussion is what is happening to the pregnancy that will come out of this successful embryo replacement.
Absolutely.
And if you put that into the decision process, and you probably are aware of what I'm meaning, what would be your choice then?
Absolutely. I'm not actually sure, because we need further work to be done for the obstetric and perinatal outcomes.
Yeah, true. Thank you.
Thank you.
Thank you. And we have another question at the back. Yes, please.
Yes, thank you.
Federico Perez from Spain. How did you estimate the risk of bias across the studies, particularly the effect of small size or the reporting bias?
Of course. So coming back to our visualization, across the domains, we had some concerns in the second domain, which was deviations from the intervention intended. And come back to this.
Okay.
What you'll find is that in the trials, some women who were started on a natural cycle had to have the intervention changed. And this raised some concerns. However, overall, we were able to continue with the study.
But this diagram represents the risk of bias within the studies, not the risk of bias across the studies.
Sorry?
This diagram represents the risk of bias within the studies for each study, but
Yes.
not the risk of bias across the studies.
Yes, we had to assess the risk of bias across the studies.
Thank you.
Thank you.
Maybe I can just ask one more question, unless anybody else wants to come to the mic. Yes, we do have somebody, yes. Please go ahead. Please go ahead.
ESHRE, London, United Kingdom.
Yes.
Just a quick question. Of the 3,198 women, do you know how many of them actually had the HRT cycle compared to the other variations of natural cycle or modified natural cycle?
I don't have the specific numbers. However, it would be great to connect afterwards and share this data.
Thank you.
Thank you.
Okay. Fine. I think that's fine. Thank you. Very well done.
Thank you so much.
Thank you for your
Thank you.
presentation.
So thank you, and let's move on to the second talk. It's now my great pleasure to invite Nadia Koroglu from Istanbul, Turkey, to present her paper with the title, Do Serum Progesterone Levels on Embryo Transfer Day Predict Live Birth in True Natural Cycle Frozen Embryo Transfer Cycles?
Thank you for introduction. Good afternoon, chairs and colleagues. On behalf of my co-authors, it's a great pleasure for me to present our work at ESHRE. Before I begin, I declare that I have no conflicts of interest to disclose. Before presenting our data, let me briefly explain why this question is clinically important. As all we know, progesterone is essential for endometrial preparation. Progesterone drives the endometrium to secretory phase required for successful implantation and maintenance of early pregnancy. And in artificially prepared frozen embryo transfer cycles, several studies have consistently shown that low progesterone levels, particularly below 10 nanogram per milliliter on embryo transfer day, are associated with lower pregnancy and live birth rates. Therefore, serum progesterone monitoring has become increasingly common in artificial cycles. However, true natural cycle differs substantially because progesterone is produced by a functional corpus luteum. And therefore, whether embryo transfer day progesterone has the same prognostic value in true natural frozen embryo transfer cycles remains uncertain. And this uncertainty is reflected in the currently available literature. The study by Gagetto Mare et al. Suggested that progesterone levels below 10 nanogram per milliliter were associated with lower pregnancy and live birth rates compared with levels above 10 nanogram per milliliter. In contrast, the study by Lawrence et al. Found similar ongoing pregnancy rates across different progesterone quartiles without identifying a clear threshold. Therefore, no universally accepted embryo transfer day progesterone threshold currently exists for true natural cycle frozen embryo transfer cycles. And this uncertainty led us to perform the present study. And our objective was straightforward: to determine whether serum progesterone levels measured on the day of embryo transfer independently predict live birth in true natural cycles. And this prospective cohort study included women between 18 and 40 years of age undergoing 430 true natural cycles at a single tertiary IVF center between 2022 and 2025. We included only ovulatory cycles with serum progesterone measurement on the day of embryo transfer and complete treatment outcome data. Anovulatory cycles, stimulated cycles, modified cycles, and serum progesterone levels below 4 nanogram per milliliter on the day of embryo transfer were excluded. Patients underwent serial ultrasound scans to monitor follicular growth, and serial serum estradiol, LH, and progesterone levels were performed to monitor ovulation. And ovulation was confirmed a rise of progesterone above 1 nanogram per milliliter and was considered the day of ovulation, the day 0. And blastocyst transfer was scheduled at day 5. And the primary outcome was live birth, defined as at least one live-born infant beyond 24 weeks of gestation. Serum progesterone levels on embryo transfer day demonstrated a broad physiologic distribution, and patients were categorized into 4 distribution-based quartiles rather than using a predefined threshold according to embryo transfer day progesterone levels. And Q1 represents the lowest progesterone levels and levels between 4 and below 9.88. And Q4 the highest and represent the levels above 16 nanogram per milliliter. And all subsequent analyses were performed using these quartile groups. And for luteal support, oral dydrogesterone was initiated after embryo transfer in all patients. And firstly, we examined the baseline characteristics of the study population. Overall, 430 cycles were included, resulting in 54.9% live birth rate, corresponding to 236 live births. No significant differences were observed between cycles with live birth and without live birth in terms of maternal age, body mass index, serum progesterone levels on embryo transfer day, infertility duration, embryo quality, and endometrial thickness. Only proportion of double embryo transfer was significantly higher in cycles, resulting in live birth. And before evaluating the association between progesterone and live birth, we examined whether the baseline characteristics differ across the progesterone quartiles. And importantly, age, embryo quality, infertility duration, the proportion of single versus double embryo transfer were all similar across quartiles. Only the body mass index showed a statistically significant difference, but the absolute difference was small and unlikely to be clinically meaningful. And all in the progesterone quartiles were well balanced. And pregnancy and miscarriage rates were comparable across all progesterone quartiles. Live birth ranged from 52.3% in the lowest quartile to 52.8% in the highest quartile, with no statistically significant difference between groups. And importantly, we observed neither an increase nor a decrease with increasing progesterone concentrations in live birth. And therefore, we found no evidence supporting a clinically meaningful progesterone threshold when progesterone was analyzed using distribution-based quartiles. We then performed multivariable logistic regression to determine whether embryo transfer their progesterone independently predicted live birth. After adjustment for relevant clinical confounders, we used the third progesterone quartile as the reference group and compare with the reference group, none of the remaining progesterone quartiles demonstrated a significant association with live birth. And as illustrated in the forest plot, adjusted odds ratios for progesterone quartiles were close to 1. After adjustment, double embryo transfer remained the only independent predictor of live birth. Because double embryo transfer was the only independent predictor of live birth in the multivariable model, we performed a subgroup analysis to evaluate whether it could mask a potential progesterone effect. When single embryo transfer and double embryo transfer cycles were analyzed separately, live birth rates remained comparable across all progesterone quartiles in both groups. And finally, using ROC analysis, we tested whether embryo transfer their progesterone improves the prediction of live birth beyond routine clinic variables. The base model included maternal age, body mass index, endometrial thickness, embryo quality, and number of embryos transferred. Adding progesterone to this base model increased the area under curve only marginally, from 0.58 to 0.60, indicating no meaningful improvement for live birth prediction. And I will briefly mention the limitations of our study. First, this was a single-center design, so it may limit generalizability of our findings. Second, although the study was prospective, it remains observational in design and therefore cannot establish causality. And finally, progesterone was analyzed using distribution-based quartiles rather than biologically validated thresholds. And in conclusion, serum progesterone levels measured on the day of embryo transfer were not associated with live birth in true natural frozen embryo transfer cycles, and live birth remained stable across all progesterone quartiles, and no independent association was observed after adjustment for potential confounders. And double embryo transfer was the only significant independent predictor of live birth. And finally, our findings do not support the use of a specific embryo transfer day progesterone threshold to predict live birth in true natural cycles. Thank you for your attention. I would be happy to answer any question.
Thank you. Thank you, Dr. Koroglu. So the paper is open for discussion. And while people are just Ernesto.
Thank you. Thank you very much for nice work. If I observe well, you mentioned that you're giving oral dydrogesterone to every patient after the day of embryo transfer. So this is not a true natural cycle. There is little phase support.
It's through natural cycle, but we give luteal support after embryo transfer.
So it's not true, should be maybe between brackets. My question is, couldn't be the case that you are rescuing those patients with low progesterone through this luteal phase support?
Yeah, we cannot eliminate the effect of luteal phase support, especially in patients with very low progesterone levels. But in every patient, we use the same protocol, same luteal phase support.
Okay, so it makes sense that you don't have any added value by measuring progesterone because you're doing luteal phase support to all of them. So this is the main limitation or consideration to take into account, I guess, because we know that even from artificial cycles, you can rescue those patients with low progesterone by adding additional luteal phase support. So just to reconsider the interpretation of your findings, I suggest you to take that into consideration.
Thank you.
Thank you. Thank you, Dr. Bose. Any other questions? Help me because, okay. So can I ask you a question?
Of course.
So can you please tell us, unless I've missed it, when exactly on the day of embryo transfer did you measure progesterone and how? What was the assay? What was the intra and inter-assay coefficient of variation? And the second part to this complex question, did the managing doctor know the value of progesterone before proceeding with an embryo transfer?
Again?
Okay. When exactly on the day of embryo transfer did you measure progesterone? Was it in the morning?
We measured progesterone levels at the embryo transfer day, before 2 hours before the transfer. And we use classic enzyme immunoassay for progesterone evaluation. And the second question?
Has it been the same throughout the 3.5 years that your study sort of lasted? Has it been the same assay?
Yes, it's the same assay.
And when did you get the results? Was the doctor performing the embryo transfer or deciding whether they will do an embryo transfer or not?
Yes,
know the result of the progesterone?
Levels on embryo transfer day below 4 nanogram, we excluded these patients. And totally we have 4 patients that have serum progesterone level below the 4 nanogram per milliliter. But above 4 nanogram, we did our transfers.
Okay, thank you. Any other questions?
Can I ask?
No, yeah.
Did the results surprise you?
No,
not at all.
That's
Do you know why? Well, it's a little bit countercurrent. You know, there have been some papers suggesting that progesterone is a predictor of outcome in frozen embryo transfer, but less so when you give luteal support, and there's a lot of work being done about that. And I think, as Dr. Boss was suggesting, all of your patients did get luteal support. So it may well have been that that was masking the result, as was suggested.
The moderating factor.
Yeah. Is
It's
that something you would acknowledge?
But in our clinical protocol, we give luteal phase support and also through natural cycles. Also, it's a question whether to give them to luteal phase support or not. Literature is not, it's not definitive for this.
Okay. But I think
it's another study question.
Yeah, so I think your study offers valuable data for those who routinely use luteal phase support after a true natural cycle, that likely they do not need to measure progesterone.
Yeah.
Thank you.
Thank you very much.
Thank you. So our next speaker is Elena Labata from Valencia. Many of you will know Elena's work in this field. Much of our clinical practice is currently shaped by her previous published work, so we're very interested to see the latest update on this area with the topic mid-luteal serum progesterone pharmacokinetics across exogenous luteal support regimens versus the true natural cycle. Thank you.
Thank you, Mr. Chairman, and thank you to the Scientific Committee for giving us the opportunity to present our study today, in which I will show you how progesterone behaves across different luteal phase support regimens in HRT cycles when compared with a true natural cycle. This is a pharmacokinetic sub-study of the PROGENDO trial. This study was partially funded by an unrestricted grant from EPSA, but the sponsor had no role on the study design, data collection, interpretation of the results. And why this matters? Mid-luteal serum progesterone levels have been really associated with live birth rates and pregnancy outcomes. And in artificial cycles, luteal phase support is mandatory because there is lack of corpus luteum, but the optimal route and dose of progesterone is still to be defined. And there are not so many comparisons directly against the true natural cycle. And this is the gap we wanted to fill. So the study question is very simple. Which luteal support regimen most closely reproduces the physiological mid-luteal progesterone profile of a true natural cycle? And to answer this question, we ran the PROGENDO trial, which is a randomized control trial performed in EB Valencia from 2021 to 25 with a blinded outcome assessment. Here you can see the endpoints of this study, and the primary one is the endometrial transcriptomic profile. But today, I'm going to show you the results of the pharmacokinetic profile and the daily determinations of progesterone from the early to the mid-luteal phase. We randomized healthy volunteers into either a true natural cycle without ACG for triggering ovulation and without luteal phase support, monitored by LH, both in urine and in serum, and also we tracked estradiol progesterone and we did ultrasound assessments. Or to an artificial cycle downregulated with a generate analog and having received estrogens from the early proliferative phase. These are the 5 groups for luteal phase support. One group received vaginal progesterone at a dose of 400 milligrams every 12 hours. Second group, subcutaneous, 25 milligrams once daily. Then subcutaneous twice daily. A combination of 1 subcutaneous in the morning and 1 vaginal in the evening. And finally, intramuscular 50 milligrams per day. Before conducting the pharmacokinetic analysis, we tracked progesterone from progesterone plus 0 to progesterone plus 5. So this means that during 6 consecutive days, we measured progesterone early in the morning at 8 a.m., just immediately before the next dose of progesterone, in order to detect the trough levels, which could be considered the minimal concentrations that the patient could have in serum progesterone levels in an HRT cycle. In the case of a natural cycle, I will show you the progesterone levels on LH plus 2 to LH plus 7. And on progesterone plus 5, we conducted the pharmacokinetic analysis in a subset of patients in which we determined progesterone during 12 consecutive hours from 8 a.m. to 8 p.m. And in the first hour, we determined progesterone every 15 minutes in order to detect any peak immediately after the administration of progesterone. So in total, we have 16 time points of progesterone measurement, and the first drawn of the day was immediately before the administration of progesterone. Here you can see the PK parameters that we analyzed, and we determined progesterone with the Roche assay with a sensitivity of 0.03 nanograms per ml. We we screened 108 healthy volunteers with ages between 18 and 35 years old and regular menstrual cycles. Finally, 90 participants were included in the study, and we measured daily progesterone in these 90 patients. Also, we did the endometrial biopsy in all of them. And finally, 74 were selected for the pharmacokinetic sub-study, but 4 of them were excluded, 2 in the vaginal group because of a protocol deviation, and 2 in the natural group because we detected a premature progesterone rise and we wanted to be homogeneous with the artificial cycles. So finally, 70 patients were included in this pharmacokinetic study with a mean age of 29 years, a body mass index of 23.5, and here you can see the number of patients included in each group for the pharmacokinetic sub-study. So let's start with the daily determination of progesterone in the early morning at 8 a.m. before the progesterone administration. Let's start with the natural cycle as a reference. Across these 6 consecutive days. Notice it starts slow and rises gradually. This is the physiological luteal rise. The red dashed line marks the 10 nanograms threshold. Vaginal starts from 0 just before the administration of progesterone on a starting day, and then quickly reaches 10 nanograms per ml and stays flat for the rest of the luteal phase. Subcutaneous once daily stays flat below 4 for the whole luteal phase, chronically below the optimal threshold. Subcutaneous twice daily looks much better. The trough stays consistently above 10 nanograms throughout the luteal phase. And subcutaneous plus vaginal looks similar to twice daily subcutaneous, hovering around 10 nanograms per ml. And intramuscular rises steadily from day 1 and stays consistently above 15 nanograms after 3 days of exposure. So just to summarize this slide, remember that these are the trough levels of progesterone, the minimum levels that the patient could have in an artificial cycle. And now let me show you the core results of this study, which is the intensive 12-hour PK analysis. I'm going to build this graph one line at a time. First, the natural cycle, again as a reference. A flat, stable profile throughout the entire 12 hours, sitting between 11 to 16 nanograms per ml. No peaks, no troughs. The vaginal progesterone lies almost exactly on top of the natural cycle. Same level, same stability. Subcutaneous once daily exhibits a completely different picture. A rapid peak within the first hour, then a steep drop, and by the end of the day, it is barely above the threshold. Subcutaneous twice daily goes even higher. Same rapid absorption and same steep drop. But because of the second dose, the afternoon levels are better sustained than once daily. The subcutaneous plus vaginal combination produces the highest peak of all, and then it drops and follows a similar pattern to the other subcutaneous regimens. And finally, intramuscular, a completely different kinetic shape. The peak is delayed, but once it gets there, it stays elevated and flat all day, around 30 to 35 nanograms per ml. It is high but stable. And here are the numbers behind the curves. The blue cells are significantly different from the natural cycle, so you can see that not a single parameter differs significantly in the vaginal group, but in contrast, all parenteral routes show significantly higher peak concentrations, average exposure, and area under the curve over these 12 hours, between 2 to 5 times the physiological values. But the trough tells an important story. With subcutaneous once daily, it drops to just 3.6 nanograms per ml, well below the optimal 10 nanograms threshold. And intramuscular, on the other hand, maintains the highest trough of all groups, consistently above 15 nanograms throughout the day. And finally, let me show you two simple metrics. On the left, the average concentration vaginal matches the natural cycle, whereas every injectable gives 2 to 3 times more. And on the right, the fluctuation index. Natural and vaginal are flat, subcutaneous swings up to 3, and intramuscular, despite the high exposure, stays surprisingly flat. So the conclusions are: vaginal route mirrors the natural cycle, subcutaneous works, but schedule matters. Once daily is not enough in artificial cycles. Twice daily is the right choice. And intramuscular is high but stable. We acknowledge some limitations because we included healthy volunteers, not infertile patients, and only serum parameters are shown here. We don't show endometrial or uterine exposure. And also because it was a PK study with an endometrial biopsy, we could not analyze pregnancy outcomes. And to finish, I would say that the clinical implication is that the same progesterone value means different things depending on the route. So serum progesterone interpretation must be route specific. I would like to thank the entire Progendo team for their dedication and hard work, and a special recognition goes to Maria Salvaleda, who is going to speak now, my PhD student, whose commitment has been absolutely crucial to making this study possible. Thank you so much.
Thank you, Elena. So we have time for some questions, if anybody would like to come to the microphone. Can I, just while people are thinking, Elena, I mean, it's very striking data, quite a remarkable difference between the different approaches, and yet we're not really seeing any, at least many of us will interpret the data as, the clinical data is not showing any big difference in clinical outcomes between the regimens. So what do you feel might be accounting for these two different positions?
Yeah, that's a very, very interesting question because obviously, I mean, we have measured so many things that it's difficult to interpret all together because we cannot say that there is an optimal route for everything. It depends on what we are looking for. Yeah. So the thing is that if we talk about pharmacokinetics, my intention is to educate people to understand how to interpret serum progesterone levels when they are determining them in artificial cycles, to know if the patient is being well exposed or not to progesterone. For example, if I have a progesterone level of 11 nanograms per ml and the patient is receiving vaginal, it's doing well, it's absorbing well the progesterone. But if the patient is receiving intramuscular progesterone, this level is inadequate because the expected mean levels should be higher. So this means that she's not absorbing well that IM progesterone. And we know that the final goal that is to reach the uterus is going to be different depending on the route that you are administering. So if you are giving parenteral routes, you should know when to measure progesterone, and according to our data, it says that it should be a minimum of 6 hours after the last administration, because otherwise you are going to be overestimating the values. And you should know what you have to expect according to the route.
Thank you. So we have a couple of questions. I think the lady on the left.
Thank you for the nice work. Rafif Musa from California. We still in the United States use the intramuscular, which is, we think that it's more persistent. So the question here is, do you think that we are overloading patients with progesterone because we are scared that we don't want to lose any embryo? And these numbers or these cutoff numbers, how did we reach these cutoff numbers? Because what matters is the progesterone level in the uterus, not the progesterone level, what is like the circulating in the peripheral blood.
That's a very nice question. It is true that the levels in the uterus have nothing to do with estrogen and progesterone levels. In fact, we published that some years ago. And I would say that it depends on the dose, because, for example, we choose 50 milligrams per day of intramuscular progesterone. I don't know how much you are giving to the patient.
We give 50 milligrams.
50 per
it
day.
was a recent discussion with Dr. Paulson from USC. The discussion is, where did we bring these numbers from, and how are we overdoing these numbers? Because, do you want me to stop? He's looking at you. I don't know if he wants to.
No, I just would like not to have follow-up questions, because there is another question. So, Elena, if you want to, provide a brief answer so we can have the last question of this talk.
Well, at the end, with 50 milligrams per day of IM progesterone, we are ranging between 30, 35. That's not so high, but perhaps it is not necessary to give such a high dose. Perhaps moving between 10 to 25, which is the physiological range, would be enough.
Thank you. And Frank? No? Okay. Thank you, Frank. Thank you for facilitating that. So we're now coming to the last talk of this session.
Thank you.
I would like to invite... Oh, thank you, Elena. And now we move on to the last talk of this session, and I would like to invite to the podium Maria Salvaleda from EV Valencia, from the same group, to present us her work on the route and dose-dependent differences in endometrial progesterone and cortisone intracrinology between natural and artificial cycles, a secondary analysis of a randomized clinical trial. Maria.
Good afternoon, everyone. Thank you for the presentation. First of all, I would like to thank the committee for selecting our work and for giving me the opportunity to present the results of this work entitled Root and Dose-Dependent Differences in Endometrial Progesterone and Cortisone Intracrinology Between Natural and Artificial Cycles. As part of my disclosure, please note that this study was partially funded by a pharmaceutical company, IPSA, which had no role in any part of the study. Let's start with a brief introduction. In the reproductive field, endometrial preparation is essential for preparing the endometrium for receiving the embryo to achieve successful reproductive outcomes. There are different types of endometrial preparation protocols that include the natural cycle and the artificial cycle. In the natural cycle, the hormones that participate in the endometrial preparation protocol are produced naturally by the body. Among these ones, estrogen and progesterone are key, and these key hormones are administered exogenally in the artificial cycle. And we are going to focus on this work on progesterone. In the artificial cycle, progesterone has been typically measured in serum, as its level has been associated with reproductive outcomes. Nevertheless, these serum progesterone levels has been seen to not correlate to endometrial progesterone levels, and their assessment is important due to progesterone's central role in endometrial function through complex intracranial interactions. Moreover, it is known that there is not a single way to administer exogenous progesterone. There are different types of progesterone and administration strategy that may differ on route and dose administration, and the best one has not been determined yet. Therefore, the clinical choice of progesterone administration strategy may have a direct impact on these intracranial interactions that are essential for the endometrial function. Therefore, the study question of this work is, do different progesterone administration routes and doses used for endometrial preparation generate distinct endometrial progesterone-related endocrine profiles? For answering this question, it was designed the study PROGENDO, which is a randomized clinical trial that has been characterized in the previous presentation by Dr. Elena Labarta. Briefly, we recruited healthy volunteers that range from 18 to 35 years old with regular cycle and no uterine or systematic pathologies. These volunteers were randomized into one of 6 different groups. Among these groups, there was the natural cycle, which is considered the gold standard, and therefore the control in our study. And also includes 5 different artificial cycles that differ on the route and dose of exogenous progesterone administration. In these groups, we can find the vaginal route, the subcutaneous route with different doses, and the combination of subcutaneous and vaginal route, and finally the intramuscular group with the doses displayed on the slide. If the participants were randomized into the natural group, they were monitored during the proliferative phase until the LH was detected and no hormones or medication was administered. In the case that they were randomized into any of the artificial cycles, they were administered the gonadotropin release hormone agonist for the regulation, and in the posterior cycle, during the proliferative phase, they were administered exogenous estrogenous. After 9 to 14 days of this exogenous administration of estrogens, we checked if the endometrial thickness was higher than 6.5 milliliters and if the endometrial progesterone was below to 1 nanogram per milliliter. If these 2 parameters were met, we started the exogenous progesterone administration according to the group that they have been randomized into. In the case of the natural cycle, 7 days after the LHR's detection, and in the case of the artificial cycle, 6 days after the progesterone exogenous administration, it was performed an endometrial biopsy for determining the endometrial intracrinology. For that, we collected the endometrial sample from 90 participants, and after excluding 14 samples due to technical or clinical reason, our final cohort consisted of 76 endometrial biopsies that were distributed across the groups as shown in the slide. Unfortunately, this exclusion resulted in a reduced number of vaginal samples available for the analysis. For analyzing the endometrial intracrinology, these samples were analyzed using the ultra-performance liquid chromatography tandem mass spectrometry to track 11 metabolites that are found in the steroidogenic pathway along with progesterone. After the analysis and excluding the ones that were found below the limit of detection and the ones that correlated significantly with the tissue weight, we could reliably analyze 5 of them in the endometrium, which are progesterone, cortisone, androstenedione, DHEA, and cortisol. Starting with the result of progesterone, we observe in this bar plot the progesterone endometrial levels displayed on the y-axis per group, and we observed that all artificial cycles exhibited higher concentration of endometrial progesterone in comparison to the natural group, which is our control in this study, with the exception of the intramuscular group that yielded comparable results. Following with the rest of the artificial cycles, we observe in the exclusive subcutaneous routes, which are the 25 milligrams and the 50 milligrams, higher concentration of progesterone endometrial levels in comparison to the natural group, even though the subcutaneous 25 milligram exhibited maternal statistical significance. Regarding the vaginal routes, which include the vaginal and the subcutaneous vaginal route, we observe the highest progesterone endometrial levels in comparison to the natural route, to the natural group, sorry. And this might be due to the fact that there's a direct transportation from the vagina of progesterone from the vagina to the endometrium, also described in the literature as the first uterine path effect. Even though we cannot completely rule out potential contamination from the vaginal capsule, it is worth mentioning that the gynecologist cleaned the vaginal canal before obtaining the endometrial sample, and also it is worth noting from our data that the combination of subcutaneous plus vaginal route exhibited higher concentration of progesterone in comparison to the exclusive vaginal route. Following with cortisone, we observed that all endometrial preparation protocol exhibited higher cortisone concentrations, even though the combination of subcutaneous plus vaginal route did not reach statistical significance. Regarding the rest of the metabolites, androstenedione, DHEA, and cortisol, we observed that the concentration of these metabolites in the artificial cycles did not differ statistically from the concentration observed in the natural group. And finally, the conclusions. One, in the artificial endometrial preparation affects the endometrial endocrinology, especially through cortisol and progesterone levels. Artificial endometrial preparation regimens alter cortisol endometrial levels, potentially influencing local glucocorticoid metabolism. And finally, future studies are required to determine the clinical implication of these results in the reproductive field. Finally, I would like to thank everyone that was involved in this study, and especially the Foundation ESHRE, well, my group from Foundation ESHRE that is led by Patricia Diaz-Jimeno, and the team from EBI that is led by Dr. Elena Labarta. Thank you for your attention.
Thank you, Maria. Thank you, Dr. Salvaleda. So, any questions? Yes. We have 5 minutes. Sash,
Thank
please.
you. Thank you for the great presentation. Elena and Maria, great presentations, great study. So my question is, Elena, you showed very elegantly the blood levels, the serum levels after different modes of administration, and you showed the endometrial levels, and there doesn't seem to be any correlation between the blood levels and the endometrium levels. So my question is, how reliable is our serum measurements, which we now do, and then base our progesterone regimens?
Well, as Elena commented in previous study, we already observed that the levels observed in the endometrium do not correlate to the blood. Even though in our study we will try to get it all together to try to get or try to answer the question of which route or for which patient or where are we going to go from now. It is in previous words they are already told that there's no a direct correlation from the serum levels and from the endometrium. So I don't know if Elena wants to add something.
No. Elena, would you like to add something to that? But no, I think we're good. Thank you. Any other questions? Do you have, if I can, do you have a hypothesis on how cortisone and cortisol seem to be sort of affected by the different modalities of luteal phase support of progesterone exposure?
Well, we looked into that, but we have several hypotheses, and we observed that progesterone has like a modulation. Well, we have the cortisol, which is the active form of cortisol. And we observe that these two are in equilibrium by enzymes. And we observe that progesterone tends to increment to active the enzymes that transform cortisol into cortisone. So we think that the higher exposition to progesterone might be altering this equilibrium and might be performing that the cortisol is more converted into cortisone, and that's why we have higher levels. And as we've seen in previous study, higher cortisol levels are associated with worse reproductive outcomes in the endometrium.
With worse?
Reproductive outcomes.
Okay.
So maybe there's maybe we have the hypothesis that there's a modulation from the progesterone to try to maintain the equilibrium in the endometrium. But also we cannot be sure that this is somehow have to be involved to the fact that there's no corpus luteum. So maybe this cortisone, it's altering also the endometrial environment. So we are not sure from which way we are working, but the hypotheses are there and we are studying on that because we think it's very interesting.
So interesting hypothesis, and obviously follow-up studies are required. One thing I would like to add, and tell me if you agree, on the basis of the combined of your presentation and Dr. Labarta's presentation, it seemed that the data confirm the first uterine pass, the first pass uterine hypothesis, where essentially vaginal progesterone seems to, at the tissue level, lead to higher progesterone concentrations. Is that what you would conclude by this data? That the vaginal progesterone, despite the fact that in the serum that's not reflected in the uterine tissue, it seems to lead to higher progesterone concentration.
Yeah, we observed that in the serum the level seems to be lower or not as higher as other routes, but in the vagina there's for sure a direct transportation that are represented.
Okay, Elena?
Yeah, no, I was going to answer your question because there's a lot of confusion about serum progesterone levels, uterine levels. So as far as we can, we have analyzed up to date, serum progesterone levels are needed to maintain pregnancy because of the immunomodulatory effects in the bloodstream. And then we need a small amount of uterine progesterone levels. Perhaps they don't need to be so high just to acquire the receptivity. This is the result of a study that we conducted just to compare serum and uterine progesterone levels. And we saw that uterine progesterone levels were the ones related to the acquisition of receptivity. But one endometrium can be receptive or can turn to be receptive just with small amounts in the serum. There is no direct correlation between one or another. So this is why we can have the explanation why with IM you have high serum progesterone levels, low uterine levels, and in the vaginal route is the opposite, and at the end of the story we compare pregnancy outcomes and they are not so different. So that's why I think that we have to look for an equilibrium. And also, I think that the results of Maria are very interesting because we see that the artificial cycle is doing something different in comparison with the natural cycle. So we have to investigate more about cortisone and cortisol levels, and perhaps could be one of the explanations why there are differences with the natural cycles.
Excellent. Thank you. Maria, thank you so much for your work.
Thank you.
So, dear colleagues, dear friends, this session has come to an end. On behalf of my co-chair, Professor Nick Macklin, I would like to thank you for attending and to enjoy the rest of ESHRE. And don't forget, we have the annual assembly, the General Assembly, in about 1 hour. Thank you all.